What's up, YouTube watchers? My name is JT, and I'm here to spread awareness about multiple sclerosis. So we're going to be watching a video by Aaron Bosher, and I'm not sure what the video is about. I just found it on here, so we're going to watch it right quick. Let's get into it. Here we go.
So you've been diagnosed with multiple sclerosis, but how do you
Yes.
know which kind of MS? I mean, how do you tell the difference between relapsing forms of MS and primary progressive MS? And how certain is your neurologist? My name's Aaron Boster. I'm an MS neurologist in Columbus, Ohio. And in this video, I'm going to be answering that exact question. How do you tell the difference between relapsing forms of MS and primary progressive MS? Don't turn away, because all of that starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. In today's video, I want to tackle a frequently asked question. How do I know that someone has primary progressive MS as compared to relapsing MS? It's often that someone will come to see me in consultation and they've been given an MS diagnosis, but they're not exactly clear on which kind they have. Maybe the neurologist went as far as to tell them you have blankety blank, but they aren't always clear on how they came up with that. So in this video, I would like to share with you how a neurologist thinks through this is PPMS compared to this is relapsing MS. When you're making an MS diagnosis, any MS diagnosis, there's 5 elements to that. The first one is the story. Now we call that the clinical history because it's all highfalutin
I have remission relapsing MS, so I'm interested in what he's trying to say here.
sounding, but it's essentially what you tell me. It's what brought you to my attention. And I'd like to talk through the story that I expect to hear in the setting of relapsing multiple sclerosis as compared to the story that I expect to hear with primary progressive MS. Grab a pen and paper and let's jump in. When I'm taking a neurological history for MS, I'm listening for an MS attack, a flare, an exacerbation, a relapse. It's all the same thing. And what I'm listening for is the onset of the deficit, how long it took to come on, how long it lasted, and then whether or not it got any better. Different neurological conditions have different onset. So on one extreme, if you have a vascular event, like a stroke, God forbid, you suddenly cut off blood supply to a part of the brain. That part of the brain immediately dies because it doesn't have any blood, and you suddenly lose a function. So like half your face droops. And that's a
As you can tell, half of my face droops. That's why when I talk, it's like it sucks, but that's what happened. And I lost all function in the brain, in my arm, in my leg, everything. So I know what he's talking about.
vascular event. So we associate the fast, sudden onset with blood vessel type stuff. On the other extreme, a cancer is oftentimes rather slow growing, and you may develop a deficit over literally months and months. And that is not what we're listening for in the setting of an attack. In the setting of an attack, we're listening for an onset that is called subacute, meaning the event initiated and kind of ramped up over a period of hours, oftentimes days. So that subacute onset is what we expect to hear when there's inflammation afoot. See, the reason that someone with MS has an attack is the naughty autoreactive immune system, which is in the bloodstream, crosses the blood-brain barrier, gains access to the central compartment, and sees the supercomputer, the brain, or the superhighway, the spinal cord, but thinks it's looking at a bad guy and attacks it using inflammation. Inflammation causes that area to short circuit, but it doesn't do it suddenly like a stroke, and it doesn't do it slowly, chronically like in a tumor. It does it over a couple days. I teach my patients that if you wake up and your hand's numb and you shake it out and it feels better, you don't have to call me.
That's so right, because I wake up sometimes and this hand always goes numb, and it's scary. I didn't know if I needed to go to the hospital or just wait it out.
If you wake up and your hand's numb and then the next day it's more numb, now I want a phone call. Because that is tripping what I call the 24-hour rule.
Mine
New
quit.
MS attacks will last longer than 24 hours, and oftentimes the ramp up is subacute. Think about this. If you got sassy with me and punched me in my cheek and my face got all puffy, Tomorrow, it's more puffy. Why? Because it's inflamed, and that inflammation doesn't go away in a couple minutes, and it's not going to last just an hour. It's going to go on for a while. So when we are listening to someone describing a neurological deficit, we're trying to see if the story fits with the subacute onset, the thing that we would expect to hear in the setting of an MS attack. Likewise, with an MS attack, particularly early on in the disease, we listen for some form of recovery. The person may have deficits for weeks or even months, and then there may be improvement. Sometimes early on, that improvement is 100% all the way back to normal. Sometimes it's not all the way back to normal, it's only a partial recovery. But again, as we think about an attack, ideally we would like to hear a story where it kind of came on, was like that for a while, and then had some degree of improvement. And that clinical history is going to sensitize the neurologist that they're probably dealing with a relapsing form of multiple sclerosis. Now, when I describe an attack to someone who's experienced PPMS, they look at me like I'm an alien. They have absolutely no idea what I'm talking about because that has not been their experience. The story that we're listening for in primary progressive MS is quite different. It's an insidious onset, at least over a period of 1 year, and oftentimes involves aspects of the spinal cord. So the PPMS example would sound maybe something like this. Doc, I used to golf twice a week and I was pretty darn good. I golfed once with my buddies in a competitive league and then once with my wife for fun. And about 5 years ago, my friends somewhat semi-politely asked me to stop competing with them because I wasn't able to keep up. And so is life. I just started to golf with my wife more. But about 2 years ago, I really struggled to finish the 18 holes, and so we started to cut back and just do, say, 9 holes. And last year, I really didn't golf very much. This year, I don't have a golf membership, and I've found that if I grab my dad's old cane, it helps me a little bit when walking to the car. Now, that story is hard to put your thumb on exactly where it started. It does not involve a subacute onset like we talked about with relapsing MS. On the other hand, what we're hearing is a slow, steady decline in function over a long period of time. That's the kind of progression that we're listening for in someone who has primary progressive MS. Is it impossible for someone with PPMS to have a relapse? No, it's not impossible, but it is not what we're listening for at the time of diagnosis. If the human being expresses that they've had an attack, that's going to be a relapsing form of multiple sclerosis. In the PPMS story, we're listening for that slow, steady decline in function where there isn't a clear-cut onset. The second element in working up an MS diagnosis is what we do on the neurological examination, or sometimes I joke, the MS Olympics. And the neurological examination is intended to help support what the person told us. So if the person told us that they were unsteady on their feet, and then we examine them and see that they're unsteady on their feet, it supports what they told us. This does not really get us closer to clarifying whether it's a relapsing form of MS or a primary progressive form of MS. Now, a seasoned MS neurologist will have some ideas in mind about things they see more commonly with PPMS than with relapsing MS. For example, with PPMS, we might see more of a myelopathic picture, meaning more spinal cord involvement, bowel, bladder, bedroom, legs, stuff like that, where that's not necessarily the case with relapsing MS, but that is not gospel. And I would submit to you that the exam by itself is not going to clarify one phenotype from the other. You've made it this far into the video. Thank you. Do me a kind favor and give the video a thumbs up. It helps teach the YouTube algorithm that you dig this content and helps push it out so more people impacted by MS can benefit. Thank you. The third element to the diagnostic criteria is the MRI. And in the ancient days of yesteryear, we literally would have different MRI criteria to diagnose relapsing forms of MS.
When I just took my MRI about 3 months ago, and it came back, they took MRI of my brain and my spinal cord. When it came back, of course, I had the lesion in my brain. It didn't spread or anything. It stayed where it was, but he found out that I had spinal stenosis. The spinal stenosis is very scary. Like I said before, I can't put my head back or anything because I get real dizzy if I do. and my equilibrium is really off. I fall all the time, and I have trouble thinking and try to put together a sentence, and it's very hard for me to do that. So go subscribe to Aaron Boster. Very informative. He's very smart, intelligent. And please subscribe to my channel and get more information about multiple sclerosis. Thank you very much. Peace.